Good evening to all, and welcome to all the students to the Jaipur Surgical Tutorial Undergraduate Online Teaching Program. And with due respect to my mentor, Professor Vinay Kapoor, and the initiator of this wonderful online teaching program, JST-UG, with the sole intention of selfless teaching program for the undergraduate students from not only our country but also from different other countries also. And also thanks to Dr. Avinash and Team Dwarka for providing an online platform, wonderful platform for a flawless recording, as well as the students are joining in the Zoom platform. And today evening we have with us none other than Professor Vinay Kapoor himself. He'll be talking on a very important issue: how to pass in an exam. Of course, MBBS exam and also MS exam to some extent. So the students will be getting maximum benefit from this. So students are requested to put their questions in the chat box so that I'll be putting up the questions at the end. And today we have also introduced one thing, that means some MCQs will be asked, and the quiz master will be Dr. Pankaj himself will be joining also. He's there. So he'll be putting some questions which will be helpful for the students for the future PG entrance exams, also for the PG's, the super specialty exam. So those will be helpful to the students. So the students also are requested to be attentive, also to be very sincere, because the students maximum attending the session will be awarded someday, definitely. So over to you, Professor Kapoor.
Thank you, Prakash. I think at least for the initial few sessions, we should also acknowledge TRIMS, because the idea generated there when the director of TRIMS, Dr. Moji Jini, invited us, a team of us, to organize a CME for the students. We should also mention Dr. Ojing Kamat's name, who coordinated that CME at TRIMS. We should also, I think, thank the students of TRIMS who proactively and very enthusiastically participated in that CME. And that is where this idea was generated. And I personally have to thank Prakash for taking over the responsibility, because although the idea is mine, but I think he is taking it forward, and it is his efforts which have seen that more than 100 of you students have joined. I am very happy to see some students from the medical colleges in Ukraine who are in India joining. Welcome to all of you. And there is also one student from Pakistan today in the chat. So my request to all the students is that please inform your friends both in MBBS and MS about this activity. And if there are any MS students, you are most welcome to join the other group, which is basically for super specialties. But some of the good students, good MS students, can benefit from that also. That is done on every Saturday, 9 to 10 a.m. That is being coordinated by my colleague here in Jaipur, Dr. Anand Nagar. So those students who are interested to join JST-SS super specialty, you can send me a private message. Don't post it on the group. Send me a private message. I will connect you to Dr. Anand. And of course, as Prakash said, thanks to Avinash for providing the technical support for both the Jaipur surgical tutorials. So with that brief, I would start with the presentation. Actually, I was supposed to talk to you about how to examine the abdomen. I was trying to prepare that presentation, but for some time-bound commitments, I could not do that. But this presentation was ready with me because I had made it to the students here in Jaipur when I came here last year. So I thought I'll share this with you. Is my screen seen?
Yes, sir.
Okay. So I bring you greetings and regards from the Mahatma Gandhi Medical College and Hospital. In Jaipur, where I have joined last year after serving for more than 3 decades at the SGPGI Lucknow. At the bottom, I think the bar is hiding my email address, vkkapoor.india@gmail.com. You can note that down. If you want to read, I think some of you might have received the thyroid chapter, which I could send only today, because last time there was a class on thyroid and I had promised that I will send it to those who want it. So after today's class, if anyone of you want any chapter, or maybe I will send you the general chapters from my book, which will cover more than what I am going to cover today about the exams. What is an examination? Actually, the true meaning of an examination is cross-examination of a witness by a lawyer or a judge in a court of law. And they want to know whether he or she has committed a crime. But in our profession, we use this term. Actually, in my opinion, the correct term should be evaluation. So, evaluation of a candidate. That means you, the student, by us, the teachers or the examiners. And ultimately, the aim is to decide whether you are going to be safe for the patient or not. That's very important. Nobody can score 100% in any exam, especially clinical exam. So what every examiner is looking for is that at your level, whether it is MBBS, MS or MCH, whether not only you are competent, but more important than that, whether you are safe. So best way to pass an exam is not to commit any blunders, not to say something which is absolutely grossly wrong. And one word or one phrase which every student should know and learn by heart is I don't know. If you are asked a question, you give that answer, you get 0 out of 0 or 0 out of 10, sorry. But if you give a wrong answer, then you get -1, -2, depending on how absurd that answer is out of 10. So you should always know and remember and frequently say, I don't know if you don't know. No student is expected to know answers to all the questions that we ask. So what are the examinations that you face? Basically, in various permutations and combinations, you have theory papers. They can be MCQs or long or short questions. Then you have the clinical or practical examination, and that is what JST prepares you, because we don't teach you theory in these sessions. Theory you can read from books, you can read from internet sources, your classes. What JST is mainly oriented is towards your clinical or practical examination, and invariably there is a viva voce where x-rays, pathology, specimen and general viva is there. So that also, if you want, we can do that. But I think the initiative has to come from the students. So you have to be prepared. You have to come with, say, an operative surgery preparation, indications, contraindications, technique, complications. You present, and one of the experts, one of the teachers will discuss, rather than spoon feeding. So briefly, about, can somebody guide me? How do I take this bar away from the bar at the bottom?
But sir, there is no bar, sir, visible on the screen.
Okay, it has shifted. So for theory paper, it's mainly knowledge and recall, that what you have read, whether you remember it, and whether then in the theory exam you can regurgitate it. But still, there are certain tips which will help you to score 1 mark extra than what you know. So always, if it is a long question or a short question, descriptive question answer, divide it into headings and subheadings. Use underlining, but don't underline everything. I've seen books of many students where every sentence on the page is underlined. Then it doesn't serve the purpose. Underlining is only to highlight some important words, phrases, maximum a sentence, not more than that, not the whole paragraph. Use color, either a color pen, but changing color from one to another will take time. So you can use highlighter, and at the end you can highlight. So use colors to distinguish between headings, subheadings, to distinguish between diagnosis, investigations, management, to distinguish between your subheadings of non-surgical management, surgical management, or whatever you want. Also, frequently use boxes, tables, algorithms, and diagrams. As is said, one picture is worth more than 1,000 words. So, what you can describe in a page or 2 page, easily you can put it in the form of a table or a chart or a line diagram, and that gives you more marks than just a descriptive test. Somebody's microphone is on. Everybody, please put your mic off. There is a background noise. Also, when there are many questions, first read the question paper carefully. It is not uncommon that students don't read the question paper. Either they miss on certain questions, although they knew the answer, or they misunderstand the question. And one example I can give from real life, when we were MBBS students, there was a question on exophthalmos. and many of my classmates wrote exomphalos. So because they had very quickly and cursorily read the question. Of course, our teachers were very kind and benevolent. They gave some marks to those also who wrote exomphalos instead of exophthalmos, but don't do that mistake. And then select which questions are easier, which questions you know better, which questions you have a mastery on. Answer them first, because that gives a good impression to the examiner. If you start with the most difficult question or the question about which you don't know much, then your first impression on the examiner is not very good. And if there are choices, make sure that you read those choices carefully. So in many papers, it could be that write short notes on any three of the following five. So then don't miss that instruction and write all the five short notes. One, it doesn't give you extra mark. And second, you are wasting your time. Now coming to the clinical examination, which as I said is the main purpose of teaching you in these JST sessions. Again, depending on the course, depending on the university, depending on what board you are following, there will be cases, long cases and short cases. I will tell you the difference between long and short cases. Ward rounds, especially in super specialty exam, there is a ward round where you will be taken around a few patients. Somebody, one of your junior colleagues will present the case, and then the examiner will ask you, what will you do? So that also is a method of evaluation. And if you are going to appear in MRCS or FRCS exams, you will have actors. So they are not patients. They are people who have been trained to give you a history. So he will give you a history as if he is suffering from periampullary carcinoma. He will give you a history as if he is suffering from ulcerative colitis, because they have been taught and trained that if the student asks this, you say that. So you have to be prepared for that. And then in many examinations now, there are spots where there is no human to human interaction. There is a specimen, there is a picture, there is a case scenario, there is an instrument, whatever, and certain question is asked. It is also possible that on one station you are shown something and then there is no question. So you spend 2 minutes there, then you go to the next station, then the question is asked. So be very careful to examine what is shown to you before you move on to the next station, because by the time you move to the next station, you can't come back. And then you start thinking, oh, I have missed this. Now, long case is an essential component of any exam, MBBS, MS or MCH, and time management is very important. So you will be told that we are giving you half an hour for this case, or you will be given 4 cases and you have 2 hours. So make sure that you divide your time very judiciously. For each case, suppose you are given 30 minutes, spend only 20 minutes on the patient. Remaining 10 minutes, think, have I missed something? Is something new come up after examination which I missed in the history? What questions are going to be asked? How am I going to answer that? Are these answers going to generate some cross questions? So spend 5 to 10 minutes on each case to streamline your thoughts, to prepare yourself to rehearse your answers. And as I will tell you later, there are some standard questions which will be asked in any case. So you should be ready and prepared to answer those questions. So in the long case, obviously you ask, that is the history, and then you examine. But after you have finished the examination, as opposed to what is written in the clinical medicine or surgery books, many a time after the examination, because new findings have come up, new information has come up, you may have to go back to the patient again and ask some questions again. So it is history, examination, and then rehistory. Also, you should write notes. Don't write everything in great detail, but write notes. Some examinations may insist that you write notes, but most examinations don't in clinical examination. But still, you should write at least some important points, and you can put them in front of your eyes so that you don't miss anything when you are presenting. Then, as I said, think and then go back to the history and examination if required again. So, for example, you did not examine the left supraclavicular node, but now when you thought that yes, there is a possibility it can be CS stomach, although I was thinking that this is gastric outlet obstruction because of peptic ulcer disease, but there is a possibility. And I did examine the left supraclavicular node. So no point, no hesitation, that go back and re-examine the patient. and then, as I said, rehearse. So in the long case, the discussion will be history, examination, and then the diagnosis or differential diagnosis and management. And remember, management includes both investigations and treatment. Unless the question is asked at the end of investigations that how would you manage this case, then obviously it is treatment. So in the history, this is the standard format, the presenting complaint. So you must start with Mr. or Mrs. So-and-so, 60-year-old resident of this place, comes to us with complaints of 1, 2, not more than 2 or 3. Don't list 5 or 6 symptoms as presenting complaints. So if the patient has multiple symptoms, you have to choose which are the 2 or 3 most important symptoms which either give you the diagnosis or tell you what the possible diagnosis can be. And then if at the end of the or as a part of the history, you do an organ or system review. This is very important for MBBS students, also important for MS students, that other systems you ask. So if suppose your patient has symptoms of jaundice, then you know it is the hepatobiliary or pancreatic system. But you need to ask about GI tract, upper GI tract, lower GI tract, urinary system. And similarly, in other cases also. And then, if you think that one of the differential diagnoses is going to be a possible malignancy, you must give a metastatic history. So, what are the common sites of metastasis of most cancers? It could be liver, but unfortunately, liver metastasis don't have any specific symptom. Many students say jaundice. No, metastasis in liver do not cause jaundice commonly. Very rarely, if there is a large metastasis sitting at the hilum of the liver, where it is blocking the main right or left duct or common duct, then it can cause jaundice. So metastasis of liver and HCC usually do not cause jaundice. Jaundice is caused by cholangiocarcinoma, by gallbladder cancer, by pancreatic cancer, by periapital cancer. So liver metastasis symptoms are same like any malignancy, which is anorexia, weakness, weight loss, asthenia. No specific symptom. Second common site of metastasis, lungs. Now again, a common mistake which students make is no history of hemoptysis. Lung metastasis do not cause hemoptysis very commonly. Lung metastases are usually asymptomatic. They can cause dry cough if the solitary pulmonary nodule is irritating a major bronchus. They are usually detected only on imaging, chest X-ray, CT, or MRI or PET scan. More common is pulmonary metastasis, pleural metastasis, which causes malignant pleural effusion, which can cause breathlessness, shortness of breath on exertion, chest pain, dull aching pain, and it can also cause signs, as I will discuss later. And then the treatment history, personal history, and family history. Now, family history, don't just say no significant family history. If you think that you are dealing with a familial disorder like familial adenomatous polyposis, if you think you are dealing with a malignancy which has a very high familial occurrence like breast cancer, then you must say there is no history of cancer in first degree relatives, that means grandparents, parents, siblings, second degree siblings and children, second degree relatives, which means uncles, aunts, both maternal and paternal. So give a detailed history. And if there is a family history, draw the pedigree chart where you use circles and squares and then say that this person in the family is affected. Now, as I mentioned earlier, you should not mention more than 2, maximum 3 presenting complaints. And the presenting complaint, which you mentioned first, should be the one which points towards diagnosis. So, for example, if the patient has gallstone disease, in large majority of patients, the presenting complaint will be pain. If it is CS-cecum, in a good number of patients, it could be lump. It could also be melena, but it could be lump. Similarly, in CVD stones, it will be jaundice. Of course, they will have pain also, but what differentiates CVD stones from gallstones? It is jaundice. Pain is present in both. And similarly, in a patient with portal hypertension, it could be bleeding, which could be in the form of hematemesis or melena. Similarly, you should mention about associated symptoms. So when you talk of pain in the abdomen, suppose it is central abdominal pain, you think of bowel origin. So whether it is caused by obstruction, so you should talk of symptoms of intestinal obstruction. And you should mention all 4 symptoms of intestinal obstruction in one go. So yes, there is history of colicky pain, but the patient doesn't complain of vomiting, abdominal distension or constipation. So the moment you mention this sentence, I know that these are the 4 cardinal symptoms of intestinal obstruction. Similarly, when you say patient has jaundice, you should talk of no history of high-grade fever with chills and rigors to suggest cholangitis. Similarly, when there is a patient has a lump, then you say there is no history to suggest GI bleed in the form of hematemesis, suppose it is splenomegaly, or in the form of bleeding per rectum, suppose the lump is in the left lower quadrant, suggesting a descending colon mass, or melena, which is passage of black, tarry, sticky, foul-smelling stools. Now, when you are presenting the history of present illness, especially in patients who have a long duration of symptoms like chronic pancreatitis, patients usually come with months and years of symptoms. Then the chronology, when did it start, how frequently or how the episodes are occurring, whether if the pain or whatever the symptom is continuous or it is intermittent, that means it comes and goes. Is the severity gradually increasing? And then what is the current status? So it is possible that 5 years ago, patient had one episode of mild to moderate pain every 6 months. It was not interfering with his or her day-to-day activity. He could sleep well, and it got relieved with simple analgesics, oral analgesics. On the other hand, the disease has progressed, and now the patient has severe attacks of severe pain almost every week, so that they are not relieved by oral medication. In the last 1 month, he has required injectable analgesic for 4 times, and he is not able to sleep. If it is a adolescent, he is not able to go to school. If it is a school teacher, she has to take 1 week of leave in the last 1 month. So that tells me that you have looked into the progression of a long-standing disease. Weight loss is very frequently asked, should be asked and mentioned. And you have to remember that you have to ask and you have to mention whether it is intentional or unintentional weight loss. Medically, it is only unintentional weight loss which is important, that the patient did not make any effort to lose weight but still has lost weight. And the causes we should remember are malignancy, but don't forget non-malignant causes: tuberculosis, diabetes, recently onset detected or diagnosed untreated diabetes, thyrotoxicosis, malabsorption, especially in children, and anorexia because of any other cause. Patients with jaundice, severe jaundice due to hepatitis, they can be severely anorexic and lose weight. And then cytophobia, which means fear of eating like in gastric ulcer, where food precipitates pain, or chronic intestinal ischemia, where again food precipitates pain, also known as intestinal angina. Now, in the history, negative history also is very important. That what is not there, because that helps you to exclude the involvement of certain organs or systems and certain diagnoses. So, for example, if the patient has pain in the right upper abdomen, you have to say that there is no history of jaundice, pruritus, high-grade fever with chills and rigors, which means that to a great extent, you have ruled out biliary obstruction. Although you must remember that CBD stones can be present without jaundice and without cholangitis. But if these symptoms are present, it indicates biliary obstruction. Similarly, urinary symptoms, GI bleed, all these negative history must be mentioned in every case. So basically, your history of presenting illness should be like a story. It should be organized and it should be a smooth flow rather than disjointed or sentences, and which is like an anecdote that you tell one joke, then you tell another joke, then you tell another joke. So it should be like a story. Now, at the end of the history, many examiners are fond of stopping you and asking some questions. So you should, once you have finished your history, you should wait and let the examiner and see whether the examiner wants to ask you. So many examiners will ask you summarize the history. So how do you summarize the history? Summary should include all positive and the important negative history also. And then you will be asked, what do you think? What do you make out of it? Or what is your diagnosis? Now, when you are presenting, you have taken the history and you have done the examination also. But at this stage, if these questions are asked, you should wipe away the examination findings from your mind. And you should think and answer these questions as if you have taken history only. Because in many cases, you will see that the impression or the diagnosis after history is something else, and when we examine, it changes. And then when we investigate, it may even change at that time. And as you would learn later, when you become surgeons, even in some cases, even at surgery, the diagnosis changes, and very rarely, even at pathology, the diagnosis changes. So you have to be prepared for that. Now we come to examination. And it is a good practice, not only in the exam, but in your clinical practice also when you become a doctor, that before you jump on to the patient, take a verbal consent in a polite way. So depending on the age of the patient, depending on the gender of the patient, depending on the educational or socio-economic of the status of the patient, you address the patient, Mataji, Behenji, Beta, whatever you think is appropriate. क्या मैं आपको देख सकता हूँ, क्या मैं आपका पेट देख सकता हूँ. And always remember that if you are a male student or doctor and you are examining a female patient, never in your life do that in the absence of a female, either a relative or attendant or a staff. Remember this and follow this very strictly. Now, place the patient in a comfortable position, and whichever system you are examining, as is said, look before you leave. That is what the predators do. They always look around, they look at the target, and then they jump. So it is always inspection before you put your hand on any organ, any system. So many things you will miss. It is not uncommon for a student to miss a scar on a parotid swelling because it is a recurrent parotid tumor, either because the patient is dark skinned or he has a beard like me. So I have a big scar on my face, but you can't see it unless you inspect my face very carefully. And you can miss pulsations, the upper abdominal pulsations, so a mass sitting on the aorta or an aortic aneurysm if you don't inspect the abdomen very carefully. Always, wherever there is an opportunity, either there are two sides or two organs, compare with the normal. So look at and examine the normal first and then go to the suspected abnormal area. And your description of findings should be pictorial. Pictorial means that if I close my eyes or if I am blind, then from your description I can make out how or what the examination findings are. And highlight. How do you highlight when you are talking? Highlight. When you are writing, you can bold, you can underline, you can color. Highlighting when speaking is that when you want to say something important, you give a pause before and you give a pause after. You slightly increase your volume and you have a direct eye-to-eye contact with the examiner. So when you are describing the site of the lesion, when you are describing the consistency of the lesion, when you are describing the fixity of the lesion, these are important findings which give you the diagnosis finally. For example, in a right eyelid fossa lump. So highlight these with these tones or modes of speaking. Now we come to, so those were general instructions about examination. Now we come to general physical examination. And it is very important that you describe the performance status and nutritional status. So either you ask or you observe the patient as the patient walks to you And in every patient with malignancy, in every patient who gives history of anorexia and weight loss, you must touch the feet of the patient. And touching the feet is not to pay respect to the patient, it is to elicit for pedal edema. So you must very carefully elicit pedal edema. A patient who has pedal edema is in poor nutrition, and then if you start talking of major surgical procedures, that means your assessment of the patient's condition is grossly inadequate. Lymph node examination also is important, and you should know the relevance of each lymph node examination. If you are talking of intra-abdominal or testicular or breast malignancy, then supraclavicular nodes, and in abdomen, left supraclavicular node is important. If you are thinking of an anorectal malignancy, then inguinal are important. If you are thinking of testes as the primary site, then abdominal nodes are also important. Many students have failed because they had a case of epigastric mass, and they kept talking of stomach, pancreas, colon, whatever, and they had not examined the scrotum, and there was a tumor in the testes. So these are enlarged para-aortic nodes at the origin of the testicular vessels. If you are thinking of tuberculosis as a possible diagnosis, then all cervical nodes are important, but the most important is the upper deep cervical, the jugulodigastric group. And if you are thinking of lymphoma, that means the clinical picture is of malignancy, but the history is long, patient is young, which is not the usual story in adenocarcinoma, then all lymph nodes, cervical, axillary, inguinal, even epitrochlear, popliteal, you should examine because they are important. And today, when you examine a patient in general physical examination, if you don't mention the BMI, which means you have to measure the height and weight, and it is a good practice to measure the breath holding time, even in exam and clinical practice, because that is a very quick, short, bedside, crude assessment of the respiratory reserve of the patient. So all these things must be a part of the general physical examination. Now, if you have a groin mass as a short case, you have to examine the limb for edema, for pulses, for pulse sensations, for venous congestion. If you don't do that, you fail. Similarly, if you have a lymph node mass, you have to examine the drainage areas. So groin lymph nodes, perineum, many students fail to examine the perineum. You can't afford to do that. And if you have a lymph node mass, you, wherever it is, you have to examine all the other nodes, and you have to look for hepatosplenomegaly, because that will be the classical presentation of a lymphoma. I already mentioned, if you have an abdominal lump, please, and as a routine, in any male patient, you must examine the testes. If in the exam the patient may refuse because he has already been seen by 10 patients, 10 students, then you must say, I wanted to examine the testes, I requested him, but he refused, and I wanted to look for any scrotal mass because I am thinking of a possible testicular malignancy as the cause of this abdominal. Similarly, if you have a hard fixed right iliac fossa mass, you have to think of various possibilities. So you have to examine the spine, although in a psoas abscess it will not be hard, so I should say right iliac fossa mass. So psoas abscess presenting as a right iliac fossa mass and causing deformity of the or restricted movement of the hip joint. So you have to think that not only what you are seeing or what the patient is pointing out, what is related to that, that also you have to keep in mind. Certain irrelevant things which at MBBS level I may accept, but I don't expect an MS or MCH student to say it. So suppose there is a lower abdominal lump, I don't want you to say that it doesn't move with respiration, because obviously it will not move with respiration. Similarly, if there is a large mass, then talking of ballotability or putting the patient in knee elbow position probably would not be of much use because it is already there. And if there is no dullness in the flanks, then there is no point in saying that there is no shifting dullness. Shifting dullness is only when there is dullness. If there is dullness, then it shifts. If there is no dullness in the flanks, what is there to shift? Again, at the end of examination, you will be asked these questions, but answer to each question is different. If I ask you summarize the examination findings, then you have to give all the findings of general physical examination and abdominal or whatever system examination. And as I said, all positive findings and all important negative findings. But if I ask you what are the important findings in examination, then you mention just 3 or 4. Also, some examiners may ask you how has the examination added to the history. So suppose the patient did not tell you that there is a lump in the abdomen, but you have found it. So then you say that this is an extra thing which I have found. And in some cases, the diagnosis may change. Now, there is a difference between summarize the case and summarize the examination findings. Because at this stage, if I ask you summarize the case, then you have to start summarizing summary from the history also, as opposed to if I say summarize the examination findings. So always listen to the question very carefully. Don't jump on the question to answer it immediately. No negative marks for even waiting for half a minute. No examiner will give you negative marks if you remain silent for 10 seconds, 15 seconds. But think what the question is and how I am going to answer it. Then comes the diagnosis. So there are 3 groups of cases or types of cases. One, where you can make a diagnosis. So elderly lady, hard fixed lump in the breast, nipple retraction, all other skin signs present, which at this stage I don't remember. Diagnosis is see a breast. Even if you are pushed, you say, no sir, my clinical diagnosis is this. Now, clinical diagnosis is what is going to be correct in 90% of cases. 10% anybody can be wrong. But don't get pushed into making rare diagnosis. Or it is possible that there are 2 differential diagnoses. Very frequent thing, right iliac fossa lump. Many a time it is difficult to differentiate between ileocecal TB or CSC cup. So depending on the age, duration, the nature of the symptoms, whether it is obstruction or bleeding, whether the mass is firm and mobile or fixed, you say that my diagnosis is ileocecal TB, but I cannot rule out CSC cup. On the other hand, you could say my diagnosis is CSC cup, but it could be ileocecal TB also. And there are some cases where you cannot make a diagnosis based on history. So a patient who has only pain in the upper abdomen, say for 6 months, no other symptoms, and on examination is essentially normal. Obviously, you cannot make a diagnosis. Even if you know the diagnosis that the patient has chronic pancreatitis, don't make that diagnosis. If you make that diagnosis, I'm going to fail you because that means you knew the diagnosis. So never ever try to find out the diagnosis in the exam, otherwise you will get biased. Then in such a scenario, you think of the possible diagnosis, and I'll come to that later. So when you give the diagnosis in a clear-cut case, then you should give complete diagnosis. I'll give you an example. So patient has jaundice, patient has clay-colored stools, pruritus, so it becomes surgical obstructive jaundice. Elderly patient, short history, severe anorexia, significant weight loss, it becomes malignant surgical obstructive jaundice. Because you have palpated a lump in the epigastrium, you think, and the patient has typical pancreatic pain, epigastric pain, which is boring into the back, you make a diagnosis of CA head pancreas. And because patient has history of high-grade fever with chills and rigors, you say associated with cholangitis. And because patient is having postprandial vomiting, which may or may not be bilious, depending on the site of obstruction, you say patient is also having gastric outlet obstruction. So that becomes the complete diagnosis. Similarly, you have a palpable thyroid, so you say it is a thyromegaly. It is either diffuse or nodular, and it is euthyroid, hypothyroid, hyperthyroid, and whether there are or there are no pressure symptoms. So give complete diagnosis, including the associated problems with that disease. Now, the third group, as I said, it is possible that you may not be able to make even a differential diagnosis. Then you have to start analyzing. So in that example, I would say that the patient can have either a disease related to the upper GI tract, that means stomach, or it could be a disease related to the hepatobiliary system, that means liver or gallbladder more likely, or it could be a disease related to pancreas. Patient is young, he has a long history of symptoms, he has no anorexia or weight loss, so I think it is likely to be benign. Out of the benign diseases of these organs, peptic ulcer disease, gallstone disease, chronic pancreatitis, in order of frequency, these are the possibilities. But don't make rare diagnosis. Don't make diagnosis of a disease of which you have not seen more than 5 cases in your last 3 years of posting or training. Okay? And again, give a complete diagnosis. So in a patient with portal hypertension, don't just say portal hypertension. Say, my diagnosis is portal hypertension, probably cirrhotic. This is the reason why it is. Child B, because patient has pedal edema, patient has ascites, there is painful splenomegaly, there are no symptoms to suggest hypersplenism. He is a bleeder, but and he has received sclerotherapy, but in spite of that, he is continuing to bleed. So I think, Prakash, I will stop here because we are already at 5:50. There are a few more things which maybe I can cover sometime later, because I think it would be better that some of the teachers on the group can make some additional comments, and then we can ask the students to ask questions.
Tabing probably raised his hand. Tabing from TRIMS. You want to say something? You can unmute yourself.
No, sir. Actually, sir, it was done by mistake, sir.
Okay, no, sir.
Yeah, Prakash, maybe you can start by adding something which I may have missed.
Yes, sir, definitely. You have almost covered it. Is abdominal examination. Almost you have introduced to the abdominal examination also, touching also to the other aspect like breast or thyroid also. So all these things which you have spoke actually will be relevant for the student for making a diagnosis, coming to the conclusion, and the common mistakes which are made by the students you have rightly pointed out. So the students also in the to add to this in the general examination, always we will be starting from the pulse, the vitals are stable, and we give stress to that. Pulse rate is 80 per minute, blood pressure is in 120 upon 80 in the right arm supine position. In that way, what happens, you will be definitely speaking about those. But 3 important things one should not forget. That means if it is a case of malignancy, but routinely also, what is the performance status of the patient, one should never forget. So the performance status, either it can be a Karnofsky's performance status or it can be ECOG scale, should be spoken. So that by that the examiner will be knowing exactly what should be the management in this patient particularly, whether it should be a conservative, if a moribund patient, so we should not tell that it is a surgery we will be doing in the management. So one should give stress to that. Second one is the hydration status of the patient, rightly said. So we should not forget about mentioning about the hydration status. And it is mostly done on the bony prominences. We should not forget about those. And third one, most important, which we often forget, that is the nutritional status of the patient. So the nutritional status, it should include all, because if we ask the nutritional status, the student will be saying it's normal or average. But how to assess that? One should know that we assess the nutritional status by estimating clinically the macronutrients and the micronutrients. Macronutrients will be carbohydrates, proteins, fat. Carbohydrate, as you all know, it should be from the, they can be estimated from the BMI of the patient, which can be easily calculated clinically. And the protein, the mid-arm circumference, and we have to take also the age into consideration. Not that in the elderly patient, the mid-arm circumference muscle wasting is there. We will be considering that it is because of the disease process. So sarcopenia can be also as an aging process. And the fat estimation can be done on the triceps skin fold thickness. So we, the students, should know where to estimate for the fat. And regarding the micronutrient, the vitamins and the minerals, essential vitamins, minerals, we should not also forget. So, what are the deficiencies? How the clinically manifest? Just like the vitamin A deficiency, biter spot. So, if there is a vitamin B deficiency, then we often see the surface angular stomatitis. So, we need to also speak about those. So, these are in nutshell about the general examination, which I wanted to give stress to this.
I think the other teachers can chip in. GV, I can see GV there. Avinash, of course, is there. Pankaj is there. Yeah, one by one.
Good evening, sir.
Yes.
Good evening,
Yes,
sir. Am I
Pankaj.
audible, sir?
Yes, we can hear you.
Thank you for your presentation, sir. One thing which I want to add is many times the students know the diagnosis. So usually the seniors tell the diagnosis and then they have the access to those bedhead tickets or IPD tickets. So do not believe on those notes. Do not believe on our seniors. It's a best that whatever you are getting, take the so do not believe on those diagnoses and do not try to take the history based on those diagnoses, which is already preoccupied in your mind. So whatever history you are getting and whatever you are getting the examination, that is more important. So otherwise, you might get misled with the whatever the diagnosis has been told by you to by your seniors. That's the point for passing the exam.
So let me give you a real life example again. This was DNB exam. The student knew that this child with portal hypertension has cirrhosis. So he presented everything fitting with cirrhosis. But if you have a child with splenomegaly and bleeding, portal hypertension, unless there is evidence of decompensation, the diagnosis will be EHPVO. It is only on ultrasound then you find that the portal vein is patent and then you say it is not EHPVO. So obviously the examiners knew that the student knows the diagnosis, so never try to know the diagnosis. Similarly, in a medicine exam, there was a patient with pleural effusion and the friends in all kind of good faith told him that this patient has massive pleural effusion. So the student described all the findings of pleural effusion. But between the time the information was given and the examination, that effusion had been tapped. So now there was no pleural effusion. So please do not even try to find out the diagnosis. It is very tempting, but never try to find out the diagnosis. And as Dr. Pankaj said, once you know the diagnosis, your mind, it is a human nature that you try to present the case fitting with that diagnosis, which clinically may not be correct.
To add to this also, let me also share the experience. Why should I not reveal it? In my MBBS, final MBBS exam, just in the center one, so I got a case of a calculus cholecystitis. So my PGs prompted me that it is a case of a chronic cholecystitis. So I just examined, there was tenderness, patient was admitted with pain, but I tried to fit it towards a chronic cholecystitis because my MBBS level definitely I'll be owing the PGs, so I know that they are more learned. But in the Viva house, what happened? The examiner caught me. So, what is your diagnosis? I told, chronic cholecystitis. Okay, so the patient is with pain since the last 3 days and with vomiting, and you're telling chronic cholecystitis. So then I realized probably I did a mistake by following the my PGs. So we should not do that. So always have your own brain to act on and you also think about it. So if you know the diagnosis or if you see the diagnosis, then it will be occupied in your mind and everything you will try to fit into it. So that's a short experience I wanted to share also.
GV, I can see Ashish Bansal there. Ashish, you want to come in?
Sir, nothing to add with that conversation is going on is up. As you have rightly mentioned, I also have few experience, but nothing to add by those experience what you have already.
Any other teacher who is online would like to come in? Okay, students, any student wants to ask anything? Any specific question in relation to history exam?
we can go to the questions. Probably 5 minutes are left. We can go to Dr. Pankaj for the questions. MCQs which he will be putting, but it will be a brain teaser for the students. They will be solving it, and next time we'll be discussing the answer. Dr. Pankaj, are you ready with that?
Sorry. So I'm ready with MCQs. Dr. Avinash, can you just allow me to share my screen?
Dr. Avinash, please make Dr. Pankaj actually the co-host also.
Sorry, I got disconnected for a minute.
Yes.
Yes.
The question session, sir. Dr. Pankaj will be presenting few questions which we prepared in the morning time.
Okay. Good. Very good. Very good. Yes.
Okay.
So while Dr. Prakash is projecting the questions, students, please email me. I have written my email address in the chat. Just write pearls in the subject. So I will send you the introductory chapters from my book, which give you a little more information about how to present cases in the exam. Okay.
I'm actually unable to share. It's not allowed.
Yeah, you have, Avinash, can you please allow Pankaj to as a co-host so that he can share his screen?
In the meanwhile, sir, I'm trying to write on the chat box. In the chat box.
Somebody from Dwarika. Yeah, I can. Yeah, so Dr. Pankaj has put some questions in the chat box. So Prakash, what is the format you want the students to answer now, or they? How do we?
Let them note it. So next time we'll be discussing in the beginning or in the middle. So
Okay.
that it is a homework type.
Okay.
Or what else we can do, sir? Because then I'm unable to share.
So I think Avinash offered that he will devise some way of projecting these questions, and then the students can answer.
Next time we'll do this.
Yes. Maybe Pankaj, you can kind of explain to the students this examination method of examination of spleen.
So the first question is, which of the following statement is not true about examination of spleen? Option number 1, an enlarged spleen descends downwards, backwards and medially. Option number 2, palpation of an enlarged spleen is best performed in a supine patient. 3, the examining hand should start in the right lower abdomen. 4, the tips of the finger pointing upwards and wrist inward. So which of these statement is correct? One statement is not correct. You can
Any
just write in the
volunteer
chat box.
student?
The students can just keep a snapshot of this. They will be solving it.
I got one answer, option number 2. Someone has written option number 2 is not correct. So we will tell the answer in the next class. So let me put the another one, next one. I got only one answer.
Ankit, you want to answer? Ankit Rana?
Yes, Ankit.
Yeah, come in, don't hesitate.
Yes, sir. Yes, sir.
Yes,
So I
go
actually
on.
my connection was lost, sir. So I didn't get the question, sir.
Sorry.
Question is there in the chat. If you want to answer,
Okay.
you read the chat and then answer. In the meantime, any other student wants to come in?
And I'm putting the next one.
These questions are on the abdominal examination, which will be a teaser for the next session, that is on the examination of the abdomen. Probably, sir, you will be taking examination of the abdomen coming week or whenever you are comfortable, sir.
No, I think let somebody who teaches undergraduates do it. I just chipped in because you didn't have anybody. So I am
Sure.
trying to contact some other teachers, but you also at your level try to contact
Yes, sir,
somebody.
definitely.
Sorry, I put it to. Sorry. Okay. Just a minute. This is the next one.
Because my limitation is that since I am involved more in teaching of MCH students, so many things we take for granted, which I think MBBS students need to be taught. For example, this first question only, which Pankaj has put in, how to examine the screen, the finer points, the tips, that is very important, and that can come from somebody who is involved in undergraduate teaching. Yeah.
So the next one is which of the following statement is not correct? Guarding represents the number one, option number one. Guarding represents contraction of the abdominal wall muscles over the area of pain. Option number two, guarding is voluntary due to spasm of the muscles as inflamed viscous touches the parietal peritoneum. C, option number C, the presence of rebound tenderness indicates underlying peritoneal inflammation. D, bone lag rigidity represents widespread involuntary guarding. Please write your answer
I think,
in the chat box.
Ankit, this is answer to which question? First one or second one?
This current one, sir.
No.
The recent one.
Screen question or the guarding question? Which one?
Guarding questions. Sir. Guarding questions.
Guarding. You are saying statement B is correct or not correct?
Not correct, sir.
You want to discuss now or you want to discuss in the next session?
Because,
So the problem is that in the next session, the same students may not be there. That is the problem.
so if they actually want to know the answer, let them join the next session.
Okay.
I'm putting the next. So this is relatively easy. It's an easy question. On contracting the abdominal wall muscle by any method, by either by the Valsalva or by raising the legs or the lower limb. So on contracting the abdominal muscle, lumps superficial to the abdominal wall muscle will become more prominent, less mobile, or more mobile. Only one is correct, not two. Only one is correct. You have to choose the best.
You have to choose the best answer.
Best answer. Most of them are writing A. A is correct. We'll not discuss it in the next class. Okay, the last one. One more. Which of the following statement is not correct? An intraperitoneal mass in contact with the diaphragm always moves on respiration. Retroperitoneal masses are always fixed and do not move with respiration. An enlarged kidney is ballotable and bimanually palpable. The observer's eye or the examiner's eye should be at the level of the patient's anterior abdominal wall during inspection. Most of them are writing B. B is correct. Yes. Okay, sir. Done from my side.
Okay. So, Prakash, you may close.
Very definitely good question. So the students will be thinking about it, and the answers of this discussions regarding this will be discussed in the subsequent class examination of the abdomen. So at least this will be inciting some thought process in the student to find out and read the books to find the answer also. So today definitely a very good discussion on the examination of a patient overall for the MBBS students, of course, and which will be helping them in the examination how to answer those critical questions which are put mostly by the examiner, and the examiner should be knowing about it. So it was a very nice session, and thank you all for joining. Thank you, Professor Kapoor, for giving time, and also thank you, Dr. Avinash and Dr. Pankaj, and also Dr. Ozing from TRIMS. Also, he has also joined. So we'll be also have a coming week. We'll be having also an interesting session which we'll be declaring very soon. Thank you, students. So be in touch with us, put questions, and also spread the news to join next week, same time at 5 p.m. So thank you all for joining.
Thank you.
Thank you.
Thank you.